Phil Cornford. I'm a consultant urologist in Liverpool. I'm also honorary associate professor at the University of Liverpool. I have a long history of interest in prostate cancer, and I'm currently the vice chair of the EAU Prostate Cancer Guidelines panel. I think it's important to assess patients' pre-existing risk for cardiovascular disease when prescribing androgen deprivation therapy, and I certainly would always do an assessment of them. For those patients who are fit and healthy and have not got any risk factors for cardiovascular disease, I don't think they need further assessment. But many patients are diabetic, or have had a previous angina, or a previous TIA, or even a previous myocardial infarction or stroke. And those patients are at significantly increased risk, and they need a more formal assessment and probably a referral on to somebody to help manage that. It's important for patients who are at high risk of further cardiovascular events, particularly those patients who've had a myocardial infarction or a stroke in the past, to understand that the agonists increase their risk of further events. This doesn't appear to be true for antagonists, such as degarelix. And as a consequence, if patients are at high risk, it's important to discuss with them the risks and benefits of these two separate groups of treatment. We're aware of recent data showing that ADT in combination has been associated with an increased risk of cardiovascular events. And it's important for patients to understand that although there was an overall benefit, it might be possible to improve this further by having a different sort of ADT. That is speculative at the moment rather than certain, but there is some randomized data to show an improvement in the number of cardiovascular events between people on an antagonist versus an agonist. A patient's GP is often the first port of call for patients who are identified as having a cardiovascular risk. GPs are used to managing cardiovascular risk, and for many patients will be able to manage that successfully. They'll also be aware of services in terms of specialist cardiology support if that's required. But many patients will be adequately managed by their general practitioner. It's important for patients to understand that there is a significant risk of cardiovascular disease and worsening cardiovascular disease if you're on long-term androgen deprivation therapy. Because that's true, careful management of cardiovascular risk factors is as important as the management of their ADT itself.
Hello, my name's Louisa Fleur. I work as the lead urology oncology clinical nurse specialist at Guy's and St Thomas's Hospital in London. Men come to us with a really variable levels of fitness and health, and with a really wide range of lifestyle habits. So it's really important to assess that from the beginning. So the sort of things that we'll be really interested in are weight and body mass index, blood pressure, cholesterol levels, dietary habits, what sort of food they eat, whether they smoke or whether they've been smokers in the past, and also their physical activity levels. So I think the first thing that men should do, or we recommend that they do, is really understand the possible effects of androgen deprivation therapy. And they can do this in lots of ways. They can talk to us, they can attend education sessions, they can read literature, they can speak to other men, for example, through support groups. And we run a group specifically for men on hormone therapy to try and to address some of these education needs. Secondly, it's really important that men, right from the beginning and during their treatment, really engage and work with their GPs or family doctors to understand their cardiovascular health and understand how they monitor it and how they optimise it. We also offer in our organisation, and if men are over 65, we offer them an assessment with our older persons assessment team, where they have a full cardiovascular check, just to really understand the baseline and try and optimise their health right from the beginning. Thirdly, we love people to really engage with physiotherapy teams so that they can look at their level of fitness, they can look at their activity and make a plan how they can really increase their physical activity and fitness. And then we also really recommend that men join a support group because it's really useful to talk to other men that are either starting out on their journey or on androgen deprivation therapy, so they can understand some of the effects, but also understand how men can live well on this therapy and some of the things that have been helpful for other people. So I think there's a variety of resources. The first one is really the health professional team they've got. So we would, again, strongly advise that they really talk to their family doctor, their GP, about their health and their risk. They set up a regular monitoring plan so that they're in charge of making sure their blood pressure's checked regularly and their cholesterol's checked regularly, and they're all on all the right medication to optimise their health. We would introduce them to any support services within the hospital, so perhaps our older persons assessment team, our physiotherapy team, our dietitians, etc., that can give them a really personalised, tailored assessment and plan to optimise their cardiovascular health. And we'd also signpost them to online resources. So in the UK, we use Prostate Cancer UK a lot. They've got some fantastic patient education on prostate cancer and hormone therapy generally, but more specifically on diet and exercise. We've got other charities such as the British Heart Foundation, which give some really great advice about healthy heart and healthy lifestyle. And then in-house, we also run some education programs, Healthy on Hormones, which again introduce men to the concept of managing their own health more proactively, and what sort of things they should be thinking about in terms of their heart, like blood pressure and cholesterol and exercise. So hormone therapy or androgen deprivation therapy is a really necessary treatment for prostate cancer. But being on hormone therapy does raise your risk of getting cardiovascular disease or heart disease, or worsening any disease that you have. But despite this, there is a huge amount you can do to really tip the balance in your favour and mitigate those risks. So the top line is speak to your GP or your family doctor and make sure that you're getting your regular checks, your blood pressure and your cholesterol, and that you're on the right medication to optimise your health. And secondly, it's never too late to exercise. And exercise doesn't have to just be the gym. Look at what you're doing already and look at what you enjoy doing. And remember that things like walking regularly, gardening, dancing, playing with your grandkids, are all really good forms of exercise. You just need something that is getting your heart rate racing and getting you moving. So my tip to you would be to find something you enjoy, perhaps find somebody that will do it with you if that will help you. And remember that good exercise is exercise that is enjoyable and regular. So find out what works for you and stick with it.
My name is Katie Zhang. I am a cardiologist specializing in cardio-oncology, and I currently work at Washington University in St. Louis in Missouri, United States. Cardiovascular risk assessment is a really important topic that forms a huge literature in the cardiology community. I would say that cardiovascular risk assessment really starts with the medical history in the interview. So asking a patient about things like smoking history, family history of heart attacks and strokes are really critical to inform the overall risk status. We also pay very close attention to the vital signs that are collected in clinic, especially the blood pressure and the weight, which then informs the body mass index. When it comes to actual blood tests, I would say that the lipid panel or cholesterol level is one of the most important tests that we have to assess a patient's cardiovascular risk. In particular, we pay very close attention to the LDL cholesterol, also called the bad cholesterol. And when that number is high, we know that the patient's risk of having a future heart attack or a stroke is significantly higher than in a patient who has a lower LDL level. In patients who have risk factors for diabetes, I also routinely check a hemoglobin A1C, which will give us an idea of how bad that person's diabetes is, if they even have it. We do know that patients with diabetes also tend to have an increased risk of a heart attack, stroke, or other blood vessel problems as compared to patients without diabetes. Now, if any of these blood tests are abnormal, or if a patient is endorsing symptoms of cardiac disease, such as chest pain or shortness of breath, then there are other more targeted cardiac tests that we check to make sure we're not dealing with full-blown cardiovascular disease. So these tests include things like transthoracic echocardiogram, which looks at the heart pumping function and heart structure. Sometimes we check a stress test, which looks for signs of blood flow problems in the heart arteries due to heart artery blockages. And then sometimes we check what's called an ankle brachial index, which measures blood flow in the legs to look for artery blockages in those leg arteries. Altogether, these tests can give us a great sense of a patient's overall heart and blood vessel health status. So there are a lot of different ways that we can quantify cardiovascular risk. One of the more popular risk stratification schemes is called the Framingham Risk Score. This has been, updated and now replaced with the ASCVD risk score, atherosclerotic cardiovascular disease risk score that the American Heart Association endorses. In my clinical practice, I would say that from a practical purpose, I kind of group my patients into big categories of low cardiovascular risk, intermediate or high cardiovascular risk. And I do that, again, kind of based on the lab testing, the medical history, smoking status, things like that. Depending on the level of risk, I may recommend statin therapy as a preventative medication. And I really use kind of our standard cardiology risk profile risk tools that I mentioned earlier to help with that statin decision. Aspirin, low-dose aspirin is another therapy that I will frequently prescribe for the higher risk patients. So I would say, from in my own personal practice, I kind of use a combination of general clinical gestalt, low, intermediate, or high cardiovascular risk, in addition to established cardiovascular risk profiles to help me make that assessment. Yes, there is a new GnRH antagonist called relugolix, which is the first oral formulation of this medication type that has been approved in the United States. And I think this is a really exciting development for our patients because in the big clinical trial that demonstrated efficacy of relugolix for treatment of prostate cancer, the investigators actually found that the rate of adverse cardiovascular events on relugolix, specifically heart attacks and strokes, was significantly lower as compared to the rate of cardiovascular events on leuprolide, which is the kind of the standard of care. The rate dropped from about 6% to about 3% when on relugolix as compared to leuprolide, so about a 50% reduction, which is significant. And, I think that this is a really exciting development, and the really makes it important for more studies to be performed on this question. In science, we always are reluctant to put all of our eggs in one basket and believe one study to be truth. We like to see it confirmed in other studies. And I would say the same for this one. We can't be totally positive that the results in this trial can be translated to the patients that we're treating every day, just because of imperfections with study design. But I do think that the findings are very exciting and more studies are needed. In terms of how this has affected our daily practice, I would say that for a patient who we think is at high cardiovascular risk, and for whom the oncologists think that treatment with relugolix would be relatively equivalent to treatment with leuprolide, we may err slightly on the side of treating with relugolix just to get that potential lower risk of cardiovascular side effects. In my own clinical practice, this has come up for a few patients, in collaboration with the medical oncologists. But I would definitely say that it's we don't take this to be definitive just yet, and we would like to see the findings replicated in more studies. So this question of whether androgen deprivation therapy, or ADT, is associated with increased risk of cardiovascular events is kind of one of the biggest, I would say, longstanding questions in the field of prostate cancer therapy. In the mid 2000s or so, there was concern raised that potentially some of these hormone therapies, specifically GnRH agonists, such as leuprolide, that they could be associated with an increased risk of heart attacks or other kinds of cardiovascular events. And this result was duplicated in certain clinical studies, but it was actually contradicted in other studies. And so, I would say that this association of ADT with adverse cardiovascular events, it's still somewhat controversial, and depending on which medical oncologist you ask, you may get different questions about how seriously we need to take this question. But I will say that at least in more recent years, particularly with emerging data on the GnRH antagonists such as relugolix, which we discussed in the earlier question, as well as degarelix, another GnRH antagonist, there does appear to be a signal that that this type of hormone therapy may be associated with a lower risk of adverse cardiovascular events than GnRH agonists such as leuprolide. So, so I do think that in high cardiovascular risk patients, a discussion is warranted between the cardiologist and the oncologist to talk about trying one of these GnRH antagonists because of the strong possibility that there may be a lower cardiovascular risk associated with them. Very recently, there was a large clinical trial performed called the PRONOUNCE trial. And this trial was designed specifically to ask the question whether degarelix was safer from a cardiovascular perspective than leuprolide. And I really liked this study because they actually specifically enrolled men with prostate cancer who were at high cardiovascular risk. So those who really stood the strongest chance of benefiting from being on degarelix. And unfortunately, the trial was terminated early for a number of different reasons. And at this early endpoint, they did not see any difference in cardiovascular safety between degarelix and leuprolide in these high cardiovascular risk patients. But what I think is really interesting about this study is that all of the patients who were enrolled in the study were required to see a cardiologist, and that cardiologist's job was to make sure that the patient was getting all of the preventative cardiovascular therapies that were necessary to optimize cardiovascular health. So things like quitting smoking, making sure the cholesterol was well controlled, starting a baby aspirin if that was appropriate, making sure to talk about weight loss and heart healthy diet. And so I think we'll never know quite for sure whether there is a difference in cardiovascular safety between degarelix and leuprolide, at least from this one study. But what I think what we can conclude, though, is that if we can get all of our patients to see a cardiologist and make sure that all of these cardiac risk factors are well controlled, it's possible that there may be no difference in cardiovascular risk between the different prostate cancer treatment agents. It's possible. And so I would argue that aggressive cardiovascular care, preventative care, is as important a component of prostate cancer therapy as the actual hormone treatment itself. I think one thing that's perhaps underappreciated both by patients with prostate cancer as well as oncologists who care for patients with prostate cancer is that actually men who are diagnosed with prostate cancer tend to be overall at increased cardiovascular risk. And this was shown in a study called the Radical PC study that was conducted by a colleague of mine, Daryl Young, in Canada. And when they looked at several thousand patients with prostate cancer at their institution, they found that 2/3 of those patients were at high cardiovascular risk using the Framingham risk model. And, it kind of makes sense. It's older men who are being diagnosed with prostate cancer. And statistically speaking, those are the men that are at increased risk for having cardiovascular disease. And so we're taking this patient population that's already at somewhat increased risk of cardiovascular disease and then giving them cancer treatments that may further increase that cardiovascular risk. So I think the first step is to make sure that patients and oncologists are all aware of the overall high cardiovascular risk of this patient population. And I think from there, that'll kind of make everyone more attuned to the importance of preventative cardiovascular therapies, whether it simply be stopping smoking or making sure the cholesterol is well controlled, making sure the blood pressure is well controlled. I think that these very simple interventions could potentially have a major impact on cardiovascular health for patients who are going through prostate cancer therapy. And this takes me back to our previous discussion about the results of the PRONOUNCE study. Although they were somewhat discouraging in that we weren't able to get a clear answer as to whether one type of hormone therapy may be safer from a cardiovascular perspective than another, I think that the results are very interesting in that they suggest that potentially if all of our patients are seen by a cardiologist and truly optimized from a cardiovascular perspective, maybe that could really lower the rate of cardiovascular events to the point where we don't need to be as particular about the choice of ADT. And so I would encourage all patients to, ask their providers about their cardiovascular risk status and whether it would make sense for them to see a cardiologist, because, we can do some pretty basic interventions with either lifestyle changes or very simple medications that could have a big impact on reducing the risk, cardiovascular risk associated with prostate cancer therapy.